Good evening. Dr. Vidya, would you like to introduce him?
Yes, Dr. Kamlesh, good evening all, and it's my pleasure to invite Dr. Sai Krishna for our AFPI webinar session. And he's head of the Department of Family Medicine at Satyasai Hospital in Puttaparthi. And it's a great pleasure to have you with us, Dr. Sai. And over to you.
Thank you, ma'am. Thank you for your introduction. Uh, s- Kamlesh sir, I've sent you a very simple slides, and you have made it extraordinary. You're just phenomenal, sir. I don't have any words to describe you actually. The moment I saw the slides, I was just out of my mind. Thank you, Kamlesh sir, for actually making this more interesting. Meanwhile, I started having certain questions in my mind. Uh, in today's world, where we are using AI and so many sophisticated laboratories and radiological investigations, I had a question in my mind: what relevance do these clinical scores actually have in our daily lives, sir? Can anyone answer? Do you think these clinical scores have any relevance in your clinical practice? You can put it in the box if you want.
In a primary care setup, they are very useful, Dr. Tul. Sir, primary care setup, they're very useful, especially when we are in a doubt whether it's anxiety, depression. Okay, so some say depression. So families, they bring together saying he's forgetful, but they don't. They take it very light, as if it's normal. So these clinical scores give us a edge over everything, no. So this really documents our diagnosis and supports our diagnosis. I think it's very relevant for a family physician.
That was a great answer, sir. But I thought some resident will answer, but not a top-notch family physician would answer this question. Yes, sir. What you have told is exactly right. Uh, for some time, I want all of you to think about this. I was dealing with a patient, which was a 25 years old female. She had actually presented with history of abdominal pain, sudden onset. She is already married and she had two children with two LSCS. Her LMP was around 14 days back. Uh, on clinical examination, her vitals were stable, pulse
Uh,
rate was normal,
Sai Krishna,
around maybe 90 to 100.
Dr.
So in that scenario, actually, we generally immediately we couldn't get an ultrasound abdomen or CT abdomen immediately. What we had was a few labs. So basically, we did some labs and we were in a fix because she had diffuse pain abdomen and clinical examination. We couldn't, there was a diffuse tenderness actually. So in that scenario, even though we had so many sophisticated AIs, labs, and so many investigations which we could do, what came to our rescue was the Mantrels or Alvarado score, sir. So with that score, we thought the probability of having an acute appendicitis was more rather than having some other problem because it is 15 days post ovulation. Even that ovulation phase also can cause sometimes pain abdomen. So in that kind of scenario where we are actually not able to decide immediately what we are dealing with, this scoring system will actually help us to come to some conclusion or at least have some probability that we are dealing with some particular disease. So when ma'am asked me to do the clinical scores, I thought of doing multiple things like cardiovascular, respiratory, and many other things. But when I actually started reading the cardiovascular system, I found out so many clinical scoring systems within the cardiovascular system itself. And there are so many changes in the present cardiovascular system, which scores which we are actually using. We'll just go through them in a few moments' time. So definitely, my answer to this is we have to use our clinical course scoring systems, even though whatever AI we are using. And if I'm not wrong, Kamlesh sir, AI is also using the same hits. It is using this scoring system based on our questions and giving us a probability.
Oh,
So if I'm not wrong.
correct.
So let me start with the first of few of the cardiovascular scores. See, some scores you already know. You already know CHA2, DS2, VAS score, Wells score, Curve score, Centaur score. These are all commonly used. So once we have put CHA2, DS2, VAS score, suppose we have a 70 years old female who is coming with AF and you put a CHA2, DS2, VAS score, where you want to decide whether you want to anticoagulate her or not. So you put the score. What after that? See, generally, previous guidelines, after putting CHA2, DS2, VAS score, you are supposed to put this Hasbled score. So in that, hypertension, abnormal renal or liver function, history of strokes, history of bleeding tendencies, labile INRs, elderly age more than 65, history of drugs or alcohol. All these things will be taken into consideration and will decide whether this patient is at high risk for bleeding or not. So once we have decided that, then we'll decide whether we'll give anticoagulation or not. But the latest guideline says this is the finally what we are going to decide is no zero for no risk for bleeding, 1 to 2 is moderate risk, more than 3 is high risk. But present guidelines say that even though your Hasbled score is saying is at high risk for bleeding, your guidelines say that the risk for having a stroke is much more than having a history of bleed. So it is better to give them an option to have an anticoagulation. And once it is in the high risk, there is no option other than anticoagulants. You cannot give antiplatelets. Clearly, there is no guideline to say there is role of any antiplatelet drugs. And to tell you further, this CHA2DS2 score itself has made some changes. If you see the latest one, that sex part is removed in the European guidelines. Now it is only CHA2DS2 VA. That sex has been removed. Additional point for female sex, they have removed it. And now they are saying that CHA2DS2 VAS score is also performing suboptimal. Now they are advocating Garfield AF score for anticoagulating people with AF. So I'm showing the same thing in the slide. These are all taken from American Heart Association 2022 guidelines. Okay. So this is the new score actually which is being shown that is better performing that CHA2 DS2 VAS scores. So other than this Garfield AF score, there is one more score called as Atria score. But now they are advocating to use this Garfield AF score than use the CHA2 DS2 VAS score. So second thing is heart. In most of the times we'll be dealing with certain conditions like patient will present suddenly with history of dyspnea, and he might be having old history of ischemic heart disease, and we are very not sure that whether this dyspnea is because of heart failure or it is because of COPD or because of something else. So this score H2FPEF score, which includes obesity, hypertension not getting controlled with more than 2 antihypertensives, atrial fibrillation, age more than 60 years. This E by E ratio is early mitral inflow velocity by early mitral diastolic annular velocity, and this is pulmonary arterial systolic pressure, that is more than 35. So with this score, we can actually try to know whether this patient is having heart failure with preserved ejection fraction or that dyspnea is secondary to some other cause like COPD or some other cause. So less than 2 is low likelihood of heart failure with preserved ejection fraction. 2 to 6, you need to do further evaluation. More than 6 is high likelihood of heart failure with preserved ejection fraction. So why I have included this is in places where actually we are working, we have so many people who are actually having COPD with underlying COPD. If you go actually into the COPD guidelines, they have introduced a new term called as tuberculosis induced obstructive pulmonary disorder. So most of the people who are having tuberculosis are asymptomatic and they are presenting with bronchiectasis. And in that scenario, whether we are looking at heart failure with preserved ejection fraction, or is it a COPD, or is it a bronchiectasis? So it is very difficult to differentiate. If you have a previous 2D echo, or recently done 2D echo to guide you in this. It will be, if you can put this score, it will be effective in guiding you what you are actually dealing with. So other scores which you can put for heart failure risk is PCP-HF risk score, which was advocated in 2019, and ARIC risk score is in 2012, sorry. And you already know that Framingham risk score, that was in 1998, if I'm not wrong. So now the other score is Padua score. See here, what are the components included is active cancer, previous venous thromboembolism, reduced mobility, known thrombophilia, recent trauma or surgery of less than 1 month, elderly more than 70 years, acute MI or ischemic stroke, acute infection or any rheumatological disorder, obesity, and ongoing hormonal treatment. So looking at this score, what is the next score which you are being reminded of? Can anyone tell? Can put it in the chat box if you want. All these components are more or less in some other score. Yeah, exactly. It's more or less looking like well score. But in a minute, I'll tell you what is the difference between well score and Padua score. See, well score is primarily used to assess the probability of DVT in a patient who is having presenting with fetal edema. Padua score is basically used to know whether this patient is at risk for developing venous thromboembolism. That includes DVT and pulmonary embolus. When you are diagnosing DVT, well score has better sensitivity and specificity than Padua score. And Padua score is used for inpatients who are at high risk for developing both DVT and PE. So I'll share you with you some case scenarios. With that, it will become more clear where we are using well score and where we are using Padua score. So this Padua score will use to know whether the patient is at high risk for developing venous thromboembolism or not. So next is in NSTEMI, this is a TIMI score. So why do we need this TIMI score? It is because if this TIMI score gives us two things. One is what is their uh, mortality at 14 days after patient developing a NSTEMI. So based on that, we will decide whether the patient needs urgent revascularization or not. So in TIMI score, we use age more than 65, risk factors for CAD, use of aspirin, known known CAD with prior stenosis more than 50%, one episode of angina at rest, ST segment deviations, and elevated cardiac markers. So low risk is 0 to 2, intermediate risk is 3 to 5, high risk is 6 to 7. Along with this, you can get scores in percentages like 1%, 15%, 20%, 33%. Based on that, it will tell you what is that is the risk of patient having mortality at 14 days after developing the MI. So with this score, we can actually decide whether the patient is going to have an urgent revascularization or not. So this score is for hypertension in age more than 40 years. Actually, it's not less than. This is score 2. See, this score 2 and score 2 OP for age more than 65 years. We use this score when the patient is actually presenting to your clinic with a BP of 130/90. Generally, as per the JNC guidelines or European guidelines, 130/80 is stage 1 hypertension when you want to know whether to treat this patient or not. So European guidelines have given a flow chart after patient comes to you with a hypertension on more than 3 occasions. You have checked the BP in more than 3 occasions, it is still 130/90. Now we want to decide whether you want to treat this patient or give him antihypertensives or not. So European guidelines has given you a flow chart. This is the flow chart. This is a very big flow chart. I don't know whether you are able to actually read that. I have made a shorter version of that. So this is cut short. So once you have a patient with BP of 120 to 139 and diastole between 70 to 90, with history of coronary vascular disease or CKD or diabetes, and if any of these things are there, they are again further calculating score 2. Okay. With score 2, if we'll predict the 10-year cardiovascular risk. Once you calculated the 10-year cardiovascular risk, again, if you go back, you see it will start with lifestyle modifications to reduce the blood pressure. After 3 months of lifestyle modifications also, patient is having persistent BP of more than 130, 80, with a risk score of more than 10, you are going to treat this patient. So when we are actually not sure whether to treat this patient for stage 1 hypertension or not, so this score 2 is going to help us. The same score, if you are using it for more than 65 years, it is called a score 2 OP for older patients. So, so far, did I make any sense to you? Anyone can answer.
Please go
Ravi?
ahead. It's very nice. Nice presentation.
Sir, sir,
Yes, yes, yes.
come. Valay sir is our guru. He is answering, but I want some of my students to answer.
Sorry, sorry.
Sir, okay, sir.
Dr. Sai Krishna, it is indeed very interesting.
Sir, I'll go into the case scenario, sir. So the first case scenario is 78 years old female presents to the cardiology clinic with history of AF and a recent diagnosis of hypertension. She has no history of stroke, heart failure, diabetes, any vascular disease. You evaluate this lady and her BP is 150/90, LFT is normal, creatinine is 0.9. So what next? What next? So it is CH to DS to VAC score. So you are going to put the score as 4. Okay, you need to anticoagulate her, and has blood score has come as low score, low risk for bleeding. So you can go ahead and anticoagulate this patient. Next scenario is a 40 years old male with a history of type 2 diabetes and stage 2 hypertension presents for a routine checkup. Sir, I'm sorry, this is stage 1, not stage 2. His BMI is 28 and his total cholesterol is 150 and HDL 60. What score do you want to apply? Yes, any of the residents can answer, I guess. Yes, exactly. Score 2, you are going to apply. So once you have put the score 2, if you think the patient has high risk of uh, more than 10% risk of coronary vascular disease in the future, so you are going to treat this patient. So risk calculated was 1.1%. So this was the scenario which I was more interested in talking about. So 30 years old male, he met with an accident and has multiple long bone fractures. He had a hip replacement and he had nailing for the both bone fractures in the left leg. This right leg, he had a history of he had hip replacement surgery after trauma. He was on ventilator for 6 days and poor respiratory drive. On 7th day, surgical nurse noted some pitting edema on the right side. So obviously, what would be your answer? What is the cause of edema? Exactly. So it could be a DVT. So well score is 5. This is a high probability of DVT. So so here you have in this scenario we have put well score because we are thinking the patient is having DVT. So let's look at the next scenario. Here you have a 60 years old female patient who is diabetic, hypertensive, CAD with severe LV dysfunction, global hypokinesia, and she's in altered sensorium since 2 years, and she's also on long-term Foley's catheter. Her BP was not recordable. Anyone asking questions? Yeah. So on examination, her BP was not recordable. Initial lab showed WBC was 25,000 and urine showed WBC, plenty of WBC and bacteria 1+. So will you consider thromboprophylaxis for this patient? So look at the difference between the previous case scenario and present case scenario. In the last scenario, we already had an edema and we were thinking it was a DVT. So we had applied well score to see whether it's a DVT or not. This lady is more or less bedridden and we want to know whether she is at risk of developing a DVT or venous thromboembolism. So previously we used well score. Now we are going to use Padua score. So Padua score is 6 and she is at high risk for developing venous thromboembolism and Hasselblad score is 2. So that is low risk. Okay, you can go ahead and route anticoagulants in this patient. So a 68 years old male presents emergency with chest pain. He has a history of hypertension, hyperlipidemia and diabetes. He denies smoking and family history of heart disease. He has been experiencing chest pain for the past 4 hours and ECG showed ST depressions. Drop T is elevated. He's been taking aspirin for the last 1 week. So which score do you want to apply? Exactly. You are going to apply TIMI score. So TIMI score is 6. That is 30 to 40% risk of adverse events at 14 days. So he needs to get an urgent revascularization. So this is the end of my talk. I think you have learned something new.
Thank you, Dr. Sai Krishna. We will wait for the questions from the audience. Meanwhile, it's our pleasure to invite Dr. Pramendra Prasad to our session. Dr. Pramendra joined little later, I think, because of the passcode issues. Welcome, sir. I'm sure all of us know that Dr. Pramendra is the president-elect for Wonkasa South Asia. Sir, do you want to have some words?
Yeah, thank you, Dr. Vidya. So it's my pleasure to be here in this CME, and since I joined late, but I was able to in some of the few slides from the previous presentation and then this presentation. So it was nice to have those presentations because those are very useful in our clinical practice. Thank you. Over to you, Dr. Vidya.
Vidya, you are muted.
Yes. Thank you, sir. We are open for questions. I'm sure there are quite a few questions people have to discuss. So feel free to ask questions.
Congratulations to one and all for this beautiful thing. Okay, so Dr. Sai Krishna, it is an excellent talk. Okay, it is enlightened all of us. Okay, so it is very useful for all family physicians because sometimes we are in a dilemma when cardiologist says something. Okay, so is in support of things or is he going against the tide? So this gives us some guidelines. Thank you very much for this excellent talk. I just want to I want you to just highlight whether to differentiate between cardiac chest pain and non-cardiac chest pain. Can you share something?
Sir, I'm not exactly aware of any score for differentiating, sir.
Okay, okay.
The only thing which I can say in answer to that question is, you see, all these scores are good, and in quite a few situations that they can be used, but they cannot replace your clinical judgment. Because, as I think Dr. Hemant had mentioned, you look into the physical, social, psychological factors and other comorbid conditions too. Then you come to a decision. So these scores are a tool which help you make a decision. They don't make a decision for you. Right? So, and by the way, when I looked into how many clinical assessment scores are there for family doctors, there are more than 2,500. I can share you the list of first 100, but I'm sure again, Dr. Shaw, that if we search, we will find it for the question which you asked between chest pain, cardiac and non-cardiac event. So has somebody looked into it? Somebody has answered. Dr. Reis, heart score components. Dr. Reis, can you unmute your mic and say what you want to say? I have to scroll down into the whole thing. Dr. Reis?
Yes, sir.
What have you posted?
This I thought to share because sometimes this in emergency department we use this heart score when the chest pain is we are not able to differentiate between cardiac and non-cardiac. So as I given this based on this score, we can like differentiate.
Thank you. And Dr. Hemant wanted, can we have a look at the score 2 slide? Which slide was that? Hemant, are you there?
Yes, sir. I'm here, sir. So there was a score 2 slide, Dr. Krishna, Sai Krishna.
Score?
Score 2. Score 2.
Yes, sir.
Previous one. Where you?
At the score 2?
No, are you sure about this under 40? Because from what I recall, I think
No, sir, it's not under 40. It is 40 to 65. There's a mistake.
Yes, that is exactly what I was wondering.
It is between 40 to 65.
Yeah.
More than 65, we use score 2 OP.
Yes. I think it is 70, I think. More than 70. 40 to 69 is score 2 and 42 more than 70 is. I mean, I thought it was a typographical
Yeah, sir, it was a typographical error. Maybe
mismatch. Yeah.
Yes.
Okay. Anybody else?
Any other questions?
Well, I just typed in this question about chest pain, non-cardiac and cardiac, and I got an answer from the AI tool that I use. It says there is no single clinical score specifically validated. I put it in the chat box.
Yes.
To distinguish between cardiac from non-cardiac chest pain in undifferentiated patients in primary care or in emergency settings. Most scores like TIMI, Heartgrace, and HEART are designed to stratify risk among patients already suspected of having acute coronary syndrome, not to definitely differentiate cardiac from non-cardiac causes of presentation. So as Dr. Bhargava rightly said, we have to apply all the clinical sense that we have in the circumstantial evidence rather than use a score.
Sir, actually, we find it very useful when in certain dilemma conditions,
Can you speak
when we
loudly?
are
Yeah, yeah,
not
yeah.
actually having immediate access to any of the labs or any of the radiological investigations. We at least have a direction what we are actually looking at.
No, no, sir, you are also right. You're so right. The question was to somebody had asked, no, that is there a score for distinguishing cardiac and non-cardiac?
Yes,
So
sir,
it is.
exactly.
So it is. So we have scores to distinguish people suspected of having coronary syndrome, whether it could, what is to be done, what is the possible outcome. But I just Googled it and saw that there is no score, I think. So I think what conventional wisdom says is right, that they first use your three-stage assessment and then go in for using whatever tools, kits that we have for further zeroing down on the choice of further management.
And also this heart score, may not be, validated, but still what it says is history, and then it says ECG, then it says age, then risk factors, and then it comes to troponin. So all the things that we assess in a patient is
Yes.
included. So probably that is one way that just you can remember how you are going to assess a patient with chest pain.
Yeah, that's a
But
good
yeah,
takeaway. Yeah.
yeah. It's a very interesting, discussion because, as quite rightly as Dr. Barma said, sir, now we have to assess the patient. We have to take a focus history. We have to do examine the patient. We have to use, our clinical acumen, and then probably when you have difficulty in interpreting, you can use as an aid these scores, and then you can come out. So that is what I think I learned from this session, and I learned a lot from all these people who spoke. That was, thank you so much for giving me this opportunity as well. So, that is what I learned. So it's clinical acumen that matters, and to apply that to make sure that you take evidence-based decisions.
Yep. And another thing to keep in mind is many of these scores, like the FRAC score, of course, the FRAC score which Dr. Hemant showed was designed for an Indian population too. Not all the scores would be relevant to the Indian population unless they are general. So, but PHQ-9 is one which has been standardized for all populations too. Use the scores with caution. But it's a good tool when you have to refer a patient or are doing a clinical audit. That might be a good tool.
Sir, as an add-on now, I would like to just bring in
Outline.
this session. Hello, sir,
Yes,
am I audible?
better now.
Sir, uh, recent gold guidelines, if you see, they have actually diagnosed COPD based on spirometry values, that is more than less than 70% is COPD. But if you see the treatment groups which they have put, group A, B, and E, that is not based on spirometry values, but instead based on MRC grading and COPD assessment tool, that is clinical assessment tool. So based on this clinical assessment tool and also MRC grading, they are dividing this groups into three groups. So based on that, they are treating whether with LABA and LAMA or LAMA with ICS or only LABA, which should be given on and off like that.
Okay. All right. Any last words from Dr. Prasad, Dr. Maitri, and Dr. Prasad?
Yeah, it was, yeah, sure. Let him talk.
Okay. Yes, Dr. Prasad. We can see you now.
Yeah, thank you, Dr. Kamlesh. So it was a wonderful presentation because those we uses in our clinical practice very rightly to just to do the screening also and to differentiate certain cases also. Those are very, very useful in our clinical practice, and it was very good presentation by both Dr. Hemant and Dr. Sai Krishna. So I congratulate both of them for this beautiful presentation, and those are very useful in our clinical practice if we stick with the guidelines. But yes, sure, those are the all the guidelines are made in the Western country that not useful in our setup also, that we have to be care of that. So I think this was a good and wonderful presentation. Thank you.
Dr. Maitri?
Yes, I can add to that. This is an eye opener where how we can use these tools actually with care, rather than just using the tools, and probably assess the patient holistically in a comprehensive way, then apply the tools when you really need it. And also, we have to look into when you use tools, we'll have to see whether these are really validated. And second thing is we have to see the sensitivity, specificity, and positive predictive value and negative predictive value as well. All these things should be taken into consideration when you use a tool. And also it should be as quite rightly Dr. Prasad said, it should be validated to our setting as well. So we have to think all these things when we use these tools, but it really is an aid when you are in difficulty to make a decision. So I congratulate both the speakers, and they were marvelous, and that was excellent presentations. Thank you.
Thank you. So, Dr. Vidya?
I think one of the key things, reason why as a CPD group we chose this topic was, as a family practitioner, what are the tools we have, how we can make our consultation more useful to our patient. Is there something which can aid in our diagnosis, in our treatment plan, how we can help our patients? So those are the things we were looking at. And when we were discussing the topics, we thought that going through the clinical scores would be an aid in our consultation, as a lot of our faculty and the mentors mentioned earlier. Yes, this is an add-on tool to our existing clinical judgment. This cannot replace our clinical judgment. Like how we are going to use our AI in our clinical practice, these tools can also be used. And but again, cannot replace our clinical judgment. These are the tools to help. And I hope with all these new tools which are coming up and the ones which are already there, if we can use it on a regular basis, that would definitely help us in our management plan. I thank all who have attended the session, especially on Saturday evening. Dr. Hemant said he will leave by 9:15 and he's still there, so I'm so happy to see that. And thank you all. And Dr. Kamlesh, before I conclude, over to you.
Oh, I think you have said everything which was supposed to be said, and it was wonderful. We had national and international audience. What more can we ask? The CPD group is going higher and higher. Congratulations to the group, and thanks to the speakers, and thanks to Dr. Maitri and Dr. Prasad for joining us from Nepal and Sri Lanka. Thank you.
I just wanted to just conclude with one thing. We apologize for the login delay. There were some issues with the passcode, but whoever have registered for the session, we will share the recording with them so that they can have a look at it whenever they have a free time. Please inform your colleagues who have registered for the session and who couldn't attend today. Yeah. Thank you.
Adding to that point, we have made 2 podcasts. The links are shared, and we will share it with you also, of Dr. Hemant's and Dr. Sai Krishna's presentations. So I can have a look, plus the video presentation recording would be shared. Thank you.
Thank you all. Have a good evening. Good night. Bye-bye.
Night.
Thank you. Bye. Night.